I'm just going to do a brief introduction and then give it away here. So Lynn, our amazing outreach coordinator at Lead and Anxiety, connected with Bailey, who is their outreach coordinator over at Center for Discovery Eating Disorder Treatment Center. And so we thought this would be a great opportunity not only to just collaborate as we do, as they are a higher level of care treatment center, and then what we do here at Lead and Anxiety when we do work with some ARFID and disordered eating. And so they offered to do a training for us that we are so thrilled to have. So Bailey, she can raise her hand. She's the one that we've been kind of talking with. And then Lorelai here, I believe is a registered dietitian. And I will hand it over to you guys to get started. Lorelai, I know there was some presentation glitches. And so if there's anything I can do, I do also have your presentation pulled up on my end. So if I can do anything to help, please let me know.
Super. Okay. Yeah, I'll just briefly introduce Center for Discovery. Lisa did a great job. We are higher level of care, so we do have 2 residential facilities. So our one in Glenview is, we call it our adolescent, but it is for female born, female identifying from 11 to 21. And they have education, so 20 hours of education, which is really great. So that gap can kind of say if there's a college student that's in school, they can maybe be more of a better fit at this adolescent house. But then we have an adult house that's 18 and up, and that's all gender inclusive. And then we have an IOP and PHP and displays. So that's kind of our higher level of care. We're really unique in that our residentials are big homes. So the idea is you're in a home and you're going to go back to a home. You're in a kitchen and you're going to go back to a kitchen, opposed to like a sterile environment. So that's our main difference, I think, between us and a lot of other people. And then we're really small. So our adolescent house is only 8 beds. Our Chicago house is only 12. And then our IOP and PHP is only 12 total. And that's from 10 and up. So if they're under 18, they'll kind of go into one room. If they're over, they'll go into another. And then in the milieu, they'll kind of coordinate together. But that's kind of our program. And then another really cool, fun thing that we just added, it's only been about 3 weeks now, but we have a Path to Peace program, which is an online IOP from 5:30 to 8:30 for binge eating only. So really unique that if somebody would like to combine it and make it a PHP, they can do 3 hours in person at our displays and then 3 hours online, because they were finding some adults needed to pick kids up and drop kids off. So that gap made a really great addition. So that's kind of our newer program in Illinois, but I won't take the floor too much longer, just overview of kind of what Center for Discovery does. So I will hand the floor over now, but if you guys have any questions, my name is Bailey. I know it doesn't say it down there, but you guys can absolutely reach out, call, text, email, whatever you need. All right. Well, my name is Lorelai. I'm a registered dietitian. My name is spelled oddly and backwards in my little thumbnail. But anyways, so first, I just kind of wanted to give the disclaimer that I'm not actually like an expert on ARFID. I am, a dietitian, and I work with folks with eating disorders. I work at the Adult Residential Center in Chicago. But we do get patients that have ARFID in our centers. So I kind of just wanted to, A, do just an overview of it as a diagnosis in general, and then B, kind of talk about some cases that I've seen and like some of the approaches that we have been taking. It is a tricky diagnosis. It's also a relatively new diagnosis. And at least in my experience, it rarely presents alone, like as like this person has ARFID and nothing else going on. So we'll talk a little bit about that. But so like as I do have a few case studies to run through at the end, and like it's not necessarily like we've known exactly the perfect thing to do, but I'm happy to talk through kind of some of the things we've tried. And I think it's maybe just worth starting to think about, because I think it can be a really challenging diagnosis to work with, but I do think there are some approaches that have been helpful. So I have a little slideshow. Again, it's not super long. Again, I'm Lorelai. This is the presentation. So ARFID is, what it stands for is Avoidant Restrictive Food Intake Disorder. This was first, I think the DSM first recognized it in 2013, and these are some of the diagnostic criteria for it. So significant weight loss, or it could be failure to achieve expected weight gain. Obviously, this comes up a lot in children, so it may just be
that there's not an ability for the child to gain weight appropriately, or faltering growth. Significant nutritional deficiency. These don't have to all present, but for example, sometimes if children are avoiding certain foods, they might be getting enough energy per se, and so be growing, but be deficient in some nutrients because they're eating only a very limited types of foods. And then oftentimes you will see dependence on enteral feeding or oral nutrition supplements if a child or an adult, a person, somebody who has this diagnosis, is not able to actually get enough of their nutritional needs met through food. And then it can interfere with psychosocial functioning. Obviously, we know that shared meals are such a part of our social culture that if you're unable to participate in a meal, it can really make a difference in how you're able to get along in social settings. So picky eating is one thing that a lot of times gets really confused. And I will say that a lot of the people that I've worked with who may or may not have ARFID, to be honest, I am not able to actually provide that diagnosis to a patient. But there are times where I'll see a patient doesn't have that diagnosis, but I kind of recognize, even if this isn't a fully diagnosed thing, it's like, I'll almost think of it as like a tendency, but they will self-describe as, I've always been a picky eater. I'm a very picky eater. So oftentimes people with this diagnosis, that might be how they identify, or what they've been told by their family, by their friends. So they can look similar initially. The difference is that in ARFID, just a few foods are accepted, whereas in picky eating, there's just a few foods that are avoided. So sometimes it just has to do with quantity. There's like 10 things that a picky eater might not like, or they may not like some aspect. But sometimes with ARFID, it can get to where you could make a list of the foods that they will accept, and that would be it. ARFID can continue to adulthood and even get worse, whereas with picky eating, it does tend to resolve. Like, kids can kind of work through it, and eventually they kind of get used to more foods, and it's not a big deal long term. And then with ARFID, there's a higher likelihood of health complications or reliance on tube feeding. Generally, picky eating, kids will still get enough. They can still sort it out. It doesn't tend to be as long of a long-term problem. I will say, like with picky eating, I worked for a little while with WIC, and where we were talking to parents about how to help their kids accept new foods, things like that. And there definitely is like a way of an approach that's considered like, this is a typical approach for, helping kids to eat, where parents offer food at a certain time in a certain place and certain foods, and then kids get to decide what they want to eat and if they want to eat. And generally the philosophy is that if kids are hungry, they will eat, and they may have preferences, and that's okay, but it takes some exposures to foods and they'll get used to them. And generally it's not considered to be like a health risk if a kid initially prefers, quesadillas to baked chicken breast, right? But with ARFID, sometimes kids will just refuse to eat, even if they're hungry, and they just like, there is that approach actually won't work with them. And in the attempt to just like assume that kids will eat when they're hungry, sometimes will result in a child just losing weight or not being able to grow. There's also with ARFID like a need to perhaps eat foods in a specific order, or not wanting foods to touch. So sometimes there's a little bit some other aspects that can go along with it as well. Now, ARFID can also differ from other eating disorders. So for example, anorexia, which is, where people don't eat and they tend to lose weight, and ARFID can both lead to weight loss, but for very different reasons. So with ARFID, the resistance to foods are unrelated to body image or desire to lose weight. That's not why they're not eating. Whereas with anorexia, part of the clinical diagnostic criteria is the intention to change or control your body, or some body image disturbance. So even with diagnoses other than anorexia, like bulimia, or even sometimes binge eating, there is some body image disturbance, and there's concern about body image. Whereas with ARFID, the reason to eat or not to eat has nothing to do with the size or shape of someone's body. And then with ARFID, the avoidance of foods can be related to, and this is kind of a list this is a small list, but there's other things as well. But fear of vomiting or choking on the food, and I heard it's interesting you're doing a presentation on like vomiting as well next time. And so a lot of times there's been a child or an adult even may have had experiences, and then usually that's the case, is that they'll have one experience and then the fear keeps them from wanting to try food again. And it might be a specific food, or it could be food in general. And then aversion to particular qualities of the food. So definitely taste, texture, color, smell, and then sometimes just a lack of interest in food in general can come up with ARFID, whereas with other eating disorders, there tend to be persistent thoughts about food. So it's a lot on their mind. They are interested in the food, but they're avoiding it despite thoughts about food. Causes, it could just be like, there could just be oversensitivity. So for example, like they might be like people who have ARFID could be sensitive to like noises as well, or easily overstimulated. And so the food can be overstimulating. Negative experiences or trauma, so that varies as well. Like that could cause them to not want to eat because they might throw up. But I have also met with people who are traumatized by foods because of other situations, like there's a correlation or an association they've made in their mind, and certain foods bring up a trauma response for them. And then genetic factors as well. So it can be something that's heritable in different ways. And so this is, as I mentioned, I feel like ARFID, in my experience, and again, the setting that I'm in is very specific. So I don't think I've ever had a patient come in who has ARFID as their sole eating disorder diagnosis. Usually they come in with another eating disorder diagnosis, but they might have ARFID on top of it. And it is a little tricky because, like, as we looked at that last slide, the distinction between ARFID and like something like anorexia, one of the big distinctions is that in ARFID, there's no concern about like body image or losing weight or desire to lose weight. So if somebody has like coexisting anorexia, like they also want to restrict food to lose weight, sometimes it's very hard for them to get an ARFID diagnosis, because if they do want to lose weight, it's considered like a rule out for ARFID. And yet in my experience, they can co-occur. Like you can also have foods that you're restricting for sensory reasons. And then the anorexia is you're restricting foods for reasons of trying to lose weight, and they really play off of each other in a kind of a tricky way. But sometimes it can actually be hard for a patient to get an ARFID diagnosis because they might have the desire to lose weight. And then the other thing is it shows up a lot with depression, with anxiety. OCD is pretty common. It's very common in autism spectrum disorder. And like I've got some like different stats. They're not all exactly the same, of course, but atypical eating behaviors are like 15 times more common in children with autism than just like in children who don't have autism. And it can affect up to like 70% of people with ASD. Again, it may not be to the level of creating nutritional deficiencies, but usually there's a lot of seeing in autism of having a difficult time accepting foods. Sometimes you'll even see it in like, well, a kid will only eat a certain brand of a type of food that they like. And this is with kids, but I see this in adults as well. I've definitely had like a 35-year-old patient who like would say, well, if they've changed the box of this food I like to buy, then I don't really want to buy that food anymore. It's like a challenge to choose that food. And so, yeah, so again, another statistic, like of children diagnosed with ARFID, 8.2 to 54.8% of them are autistic, which is a pretty broad range. So I feel like there's not like solid statistics on this, but it does tend to be pretty common. ADHD is also a very common co-occurring diagnosis. And then I talked a little bit about eating disorders. All right, we can go to the next. Presentations, I mean, similar to those of weight suppression seen in other eating disorders. So that would include things like weight suppression. Some of the things that we screen for weight suppression are things like thinking about food all the time. Now that actually is not necessarily all that common in ARFID, but it's maybe more of a thing of like they may have trouble concentrating, or they may have lack of attention just because their brain's not getting enough fuel. So in addition to weight loss, we also see like hair, skin, and nails, or digestive issues that are based on just the body not having enough energy to kind of keep up on some of those functionalities. Slow growth, so if a child is still growing, you can see the growth curve slow. Nutrient deficiencies, so they may, again, be getting food, but maybe not. If they're avoiding fruits and vegetables, they might be missing a lot of macronutrients. And then high levels of stress around eating is something else that tends to come up. So eating disorders do tend to have anxiety with eating, but it has to do, it's a slightly different variant, I would say, what the stress is, but like just the idea of having to face foods that they're afraid of or wanting to avoid can just create stress with the idea of eating at all. Treatment management, and I think this is something that is still, getting worked out, like what are some of the best ways to do that. So from my point of view, again, this is something that I think this one is a little tricky in certain settings, but prioritizing energy sufficiency of the diet, I think from my point of view, is the most important thing. And then after that, you can start to work on variety. Because I think that if you are trying to push variety and energy sufficiency is low, if the person's just going to reject that variety, you're never going to get them nourished enough to be able to like take on that variety. So I feel like that it can be tricky in an eating disorder setting, because we are trying to work on variety with most people, or we're trying to normalize eating patterns and offering people a range of foods so that they have nutritional sufficiency like across the board. But truly, if somebody won't eat food, it doesn't help to put it in front of them. So coming up with ways to make sure they're just getting enough like calories legitimately, and then work on adding foods if possible. And then CBT is considered the sort of mainstay therapy for that, and then exposures, so like ERPs. Again, sometimes these, I'm sure you guys have worked with ERPs before, where you're doing like exposure response prevent, or where you're trying to get them used to the response and conditioned to it. It can take a really long time, and like if you've got a patient who's got 12 foods that they'll eat, it's going to take a really long time to try to introduce another 12. But I think they have to be really motivated to do it. And if they're not, it can be really challenging. And so then I say, again, you kind of have to go back to energy sufficiency. You got to keep that up, because the introduction of foods might be really slow, and they may not be as motivated, because it's really hard to add in, like if you hate eggs, it's really hard to convince yourself that it's worth the effort that it's going to go through to deal with eggs that many times, that you might then at some point say, I guess I can put up with these, which might be as far as it's going to get to. So then I just wanted to look at a couple of case studies here. So the first one I've got is a 20-year-old using they, them pronouns. And I just kind of put down some of their diagnosis, so you can kind of see that this is rarely coming in like with a single ARFID, that's it, right? So this patient actually was diagnosed with ARFID, as well as anorexia nervosa, restricting type, generalized anxiety disorder, social anxiety disorder, OCD, and then ADHD as well. They were somebody who really tried to push themselves. They really were interested in getting through their anorexia, but they weren't very interested in challenging their ARFID. They were capable, and this is something that I thought was helpful, they were capable of distinguishing between the foods that they were avoiding because of their anorexia and the foods that they were avoiding because of their ARFID. So we were generally able to challenge them on the anorexia foods, which I think for them was more like, sweets and like carbohydrates, things like that, whereas their ARFID foods tended to be like things like, quinoa, or things that had specific textures. For some reason, I remember quinoa was a tough one for them. So things that had like kind of a grainy, gritty texture. Some of the like mushy textures tend to be really hard. And so that was for them a texture thing. And we had to have conversations about, is this a food that you actually are struggling with for a texture reason, or is your anorexia kind of trying to co-opt this ARFID diagnosis for its purposes? And I think that can be a challenging conversation to have. And I think in this instance, this patient was quite motivated to work through their anorexia. But that's the thing, is that sometimes eating disorders are really sneaky. So they will sometimes say, okay, well, I can say that, anything chocolate or anything sweet is an ARFID thing, and then I can use that. If they're saying they want to get over their anorexia but not their ARFID, like sometimes patients can kind of manipulate how their diagnoses are working for or against them. So this patient was actually pretty motivated. They did struggle, however. They were a little bit with black and white thinking, and that they were pushing themselves through meals that were really, really uncomfortable for them. And they did throw up one time at the table, and then were feeling nauseous for a while. And so that, I think, increases the avoidance. We had a session in my office at one point where we were talking as they were eating, and they ended up throwing up in the trash can in my office. So at that point, we kind of talked about maybe having conversations that, in a session where maybe challenging some things, maybe that's not the best setup for when you're eating, even though they had said they had that preference to meat. But at the same time, it was okay, but if you're getting more anxious during the session, and you may not recognize it, but your body is having this response. So it took a little bit of working through all of that. They were able to regain enough weight to be able to step down. But I think they very much wanted to work through their anorexia, but they really didn't want to work through their ARFID. And they probably didn't have as many food restrictions that they couldn't be sufficient. But I think then you have to kind of come up with how can you be sufficient even if you're not going to eat all foods? Do we have enough foods in all categories? And we found that they did, but they would have to be pretty mindful about utilizing them. The next patient that I have, again, is an older patient who had a long history with eating disorders. And this person was not diagnosed with ARFID, but did present very much like an ARFID patient, very much someone that the particular food avoidances overlapped, and it was very sometimes hard to tell. I think she was someone who very much wanted to be honest whether a food was related to, for example, she was avoidant of all foods that were white in color. And I think this was related to her trauma. I was not her therapist, so I don't know why. She was with us twice. At one point, she was able to start reintroducing some white foods one at a time. And then she stepped down and came back to us, and she told me she could not tolerate any white foods anymore. She was aware that that was probably not something that she could do long term, so she wanted to get past it. But there was a really high level of she just her emotions were very volatile, and so it was really a struggle. And so what we did with her is came up with a plan of literally a plan of meals. And we actually do this now at CFD with most of our patients, especially ones who struggle with specific foods, where we literally have a backup plan for breakfast, for snack, for lunch, for snack, for dinner, for snack, where if they're not in a space, and we use, I think the methodology is based on kind of polyvagal theory. If they're not in a space to challenge themselves in the moment, if they're not in a space to make a difficult choice, they have the option to go to something that's very safe for them, and they will still meet their body's needs. And this was actually super supportive for this patient who really did want to be able to challenge foods, but had a lot of dysregulation when she was with us, but was often still able to, at least from a nutritional standpoint, a sufficiency standpoint, meet her body's needs by having the option to choose foods that felt more safe for her. So again, that's not end game, right? But that's sort of we need to have a stable platform for you to work with. And so then from there, we can challenge foods one at a time. And I think that that's something that CFD has actually introduced just in the last year that's been really, really helpful with patients who do have a lot of specific food aversions, is saying, okay, we have a cycle menu that includes all foods, but if that's not going to be tolerable, we're going to have a set menu just for you that's easy for the kitchen to prepare, but that you feel really safe with, so that on a day you can choose to challenge yourself, or you can choose to be safe but still make sure your body's nourished. And I found that that has been really supportive. I do think that like in our setting, it does take like the whole system to be able to do that, because the kitchen is very much involved, and it can, and I think we, you know, all patients kind of have to have that option, so that it's not just like one patient being singled out that's going to have an Uncrustable for dinner instead of, you know, the whatever it is that they're serving for the main meal. But again, this was a challenging patient, and I think she's actually had to step up as well. So she's got a lot of other issues beyond her eating disorder that are a struggle, but I think it's an ongoing back and forth with the multiple diagnoses. And then finally, this is a younger patient that I'm currently working with, and again, anorexia nervosa. She came in and was vomiting at pretty much all meals and snacks. And it turned out it was more of a regurgitation than a vomiting situation. And we talked through that. A lot of food intolerances, and hard to tell whether the intolerances are playing into the vomiting. But the other side of it is that when that happens, like the vomiting is reinforcing like the aversion to the food. Again, this patient does not have an ARFID diagnosis, but presents very much this way. Recently, we did end up having to, and I mean, she opted to get a tube, and thus far, when she's fed through a tube, she's not been regurgitating like the contents of the tube. And so she may just need to be supported from a sufficiency standpoint, while considering whether or not she's going to be willing to challenge some of the foods, because she's got a pretty short list of foods that she prefers. For example, will eat like the chicken noodle soup that her grandmother makes, but refuses to even try anything that's different than that. Like open to like eating rainbow goldfish, but will not eat like regular goldfish crackers. And so a lot of them are very, very specific. And again, with this patient, who's a young patient, and I think also struggling with motivation, it's sometimes a little difficult to discern like what is the reason behind why this aversion is occurring. Is it because it makes your stomach feel bad? Is it because you're worried that it's going to make you gain weight? Is it just a personal preference? Is the preference something that you're willing to challenge? And so I think challenging it is something that's going to take some time. But in the meantime, like our focus is on helping to get her nourished. I put in the hypermobile Ehlers-Danlos syndrome here just because I thought it's interesting, because that can cause some GI disorders. So again, when it comes to like, where did this ARFID presentation come from? Like it may have come from like an initial pickiness, or it may have come from an initial like heightened sensitivity, or it may have come from this patient has GI disorders that have triggered like a lot of like susceptibility to not being able to tolerate foods, which has made her very food averse in general. So it's sometimes a little bit hard to like say, hey, this is exactly why, and this is exactly what's going to resolve this situation. These can be a little complex. And so that's kind of what I wanted to just point out, is that usually it's rarely like, hey, this is just the single diagnosis and we're just going to do ERPs to help you get used to it. There are oftentimes other mitigating factors and challenges that can show up with folks that have ARFID presentations. And again, some of them don't even have that diagnosis yet. So that's kind of what I've got. And I know I feel like I've gone a long time. So if anyone has questions, let me know. I will do my best from my point of view.
No, that was great. Thank you so much. I had a quick question, if I can kick it off, and then of course if others have questions, feel free to chime in. Can you talk to us a little bit about, like, I guess, parental, like helping parents, you know, if it's a child or an adolescent with ARFID, kind of on either end of the spectrum, right? So I think I've seen it like on occasion, certainly clients we see that maybe have ARFID and or like autism spectrum disorder, and maybe parents are accommodating of it a bit, right? Like only buying those rainbow goldfish.
Yeah.
Right. One side of the spectrum. And then I've seen kind of the other end of like parents really pushing child, right, with ARFID of like, you know, maybe beyond what is like appropriate. So it'd be helpful maybe just for you to kind of share a little on that note.
This is probably going to be a lot of opinion, because I don't know that there is a one right approach. So
Sure.
I would say, like, with kids that don't have ARFID, I do know that there are a lot of parents that will accommodate their preferences left and right. And I don't know that that's really like the ideal approach, right? Where you would say, like, again, like I talked about, it's like the Ellen Satter approach to helping kids, I just like the division of responsibilities in eating, where the parents should be the ones choosing what the kids are eating when, and then the kids, once the food is in front of them, the kid can then choose if they even want to eat, and maybe they're not hungry and they choose not to eat, or which foods that are in front of them they want to eat, and how much of which foods. And that really is the idea, that like the parent chooses the food. The kids should be having the same foods that the parents have. The parents are providing nutritional variety, but that's sort of I would say like the gold standard, right? And that when the kids are hungry, they're going to eat. And so in general, like if a parent is really accommodating a picky eater, that would be the advice I would give to them, and say, listen, this might take some adjustment, but if you put these foods in front of the kid, they're gonna get used to them. They're gonna eat them because otherwise, if they say no and you give them chicken nuggets, they're gonna know that they can get chicken nuggets if they say no, right? Like that's the easy answer. So that, I would say, is the case for kids who like are just typical picky eater kids. I think it is that tricky place when you do realize that a kid is just not going to eat, and you've tried that approach for a long time. And it probably is very much more common in autism. And I think there probably does just need to be some therapy there to support, because it's going to have to be a balance, making sure you don't want that kid to starve. But at some point, there may need to be like a very focused way to challenge some of those foods. So I don't know. Again, in treatment, we probably approach it different than long-term solution situation. But we do make sure, or we at least do our best. Like, okay, so what are some proteins that are acceptable? What are some vegetables that are acceptable? What are some fruits that are acceptable? And if we have enough things in those categories, then I think the attempt for the parent to try to say, okay, we can plan some family meals around these foods, so that it's not like this kid is isolated and the only one eating these foods, but like really doing your best to kind of adapt meals so that there's at least one or maybe two foods in that meal that that child is likely to choose, as opposed to I'm going to make a completely separate meal, if you can, right? And I know that it depends. If a kid has got only 4 or 5 foods that they'll eat, and I have seen this. When I did one of my clinical rotations at Lurie Children's, there was a young man in there who had basically had 4 foods that he had eaten. And this is another thing I didn't really mention, but had burnt out on one of them. So that's the other side, is that if there's only a few foods that the kids will eat, sometimes they'll burn out on certain foods because they're so repetitive. So there is a need at some point to up variety so that you're not running out of options long term. So I think that the idea would be can you push variety as much as possible, but still with awareness that this child does need to have enough food. And honestly, if they get to one meal and all they will eat is the watermelon at that meal, that's probably not the end of the world. But there probably should at some point be a targeted way to try to build towards in variety, is at least having enough foods in each food category. So there's, even if there's only 2 vegetables that they can tolerate, can one of those vegetables be served most nights of the week? So that's again a little bit of more opinion, but I think it's gonna be a different approach than with just typical picky eaters. Because if there really is an inability to eat the foods and not enough, perhaps even awareness of hunger, or that, sometimes that is true with ASD as well, is that feelings of hunger aren't coming through in the same way. And so that distress of hunger is not outweighing the distress of the food in front of them.
That's super helpful, Laura. Thank you so much.
Mm-hmm.
Great answer. Other questions? I didn't want to be the only one. Other people have, feel free to share them or put them in the chat.
Yeah, Lorelai, quick. Oh, sorry, Sarah.
Do you want to go? You go ahead.
Okay, I'll be quick. My question for you, Lorelai, was just the idea of, I know for a lot of parents there might be concerns of like, hey, how do we implement this, or what can we see at home? And I wondered if you had any advice for what we could tell parents for supporting, and just, I know there might be a lot of shame is this picky eating idea and different styles of parenting. So if you had any pointers on that, that'd be huge.
Yeah, I mean, I'm not a parent myself, so I always am like, I'm sure every parent has challenges that I can't even imagine, right? And I think, for parents, like, just do your best, right? It's not going to always be perfect. I think that's the other side of it is like, I do think that there are some strategies to help support your kids if we're talking about kids, right? I mean, some parents might have some of these aversions as well, right? It's okay for kids not to like everything, and they are allowed to have preferences. I do think it's just and I think we know from, I don't know, I know from experience that like forcing a kid to sit in front of a plate of food until they finish is never going to be supportive long term, because that's just going to add to their trauma and resistance. So at some point, I think, parent, you do your best. You don't make an issue of it. You put the foods in front of them. And if you are finding that this child is like failing to thrive because they are not eating enough, then yes, there does need to be some intervention. But I think making a big deal of it at the table can actually exacerbate the problem, and it can create that anxiety that comes just around the idea of eating at all. So even though it might be stressful for the parent to not try to really, really, really push their kid to eat that food, at some point that child's going to have to make that decision about what they put in their body, and they probably do actually need to have that body autonomy. So I don't think it's like the end of the world. I do think that you do need to figure out a way to approach it if they're just not getting enough. But at a meal is probably not the moment to do it if that's going to cause more stress.
Thank you.
I was hoping you could give a little more insight to some, clients without kind of the eating disorder piece. I feel like at Light on Anxiety, we deal more with, like you were saying, maybe someone on the spectrum or ADHD or things like that, those comorbidities. And once they're kind of, unless the eating disorder is like mostly in remission, and somebody correct me if I'm wrong, I'm pretty new, but that seems like they would maybe need a higher level of care.
Yeah, I mean, so just because my background, I'm only working with eating disorders right now. So that's more my background. But I think, ARFID is an eating disorder. Obviously, that is what it's considered. It's just, I think the main difference is that it doesn't have that body piece to it, like trying to lose weight or trying to be of a certain size. So I think it's like I guess I would say like, it's always tricky with kids, but I do think like there probably does need to be some motivation behind why it's important to challenge the foods. Again, when I'm talking with people with anorexia, probably they're in treatment for that reason. So their ARFID tendencies may not be like so bad that they can't continue to live with some resistance to certain foods. But I do think that like if ARFID is really the reason why they've lost weight, the reason why they're not thriving, then kind of like any other eating disorder, there's got to be some motivation to recover, or it can just be like, it just can be like butting heads with something like that, right? So I guess that would be what I would say is like anything else, like work on what's the motivation, because it probably is going to be a slow process, like stepwise, to start to build up the foods. And it probably isn't going to be super fun. I mean, you're asking somebody to choose to eat something that they really don't want to and that they really feel uncomfortable with. And so if they have no other reason than they're being told to do so, that may not like win the day long term. that's kind of what my thought is, but I wonder if anybody else on your team has a thought about that as well. Again, I'm generally coming from the eating disorder point of view, and although ARFID I'm generally not seeing that as the top presentation where I'm working. Anyone else have thoughts, or like, because I'm honestly curious too, like, are there some other ways that you've approached that with folks?
Oh, Lynn, you raised your hand. I didn't know if you wanted to chime in on that or
Yeah,
otherwise.
so I don't like, I'm not a therapist. I don't have, I just have parenting experience. And so what I was just going to share was my daughter's now 17 at 6 years old, super picky eater her entire life till today. I'm picky eater. My husband's picky eater, blah, blah, blah. And we went to a program at Duke University at the Center for Picky Eating. They also do, I'm sure you guys know, they do obesity, anxiety, etc. But I just was going to share for 1 second what we learned, because I think it was really helpful. And I did tell Dr. Deborah, we have this information and I'm going to find it and bring it in. But basically, they check everybody's senses, et cetera, blah, 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 make sure everything's working correctly. But it's exposure. It's what you guys do. But the way they did it was pretty cool. They had a program, super easy, called Just the Facts. And what they were trying to do is take the emotion out of it and have the kids just focus on, and I mean, this is adults too, focus on color, texture, like everything with your senses. How does, smell, sight, sound, etc. And they, for the exposures, they would just have like literally a fingernail piece of the food to try to make it super small. You would put it like in the back of your mouth because your taste buds are more prominent in the front. And it's obviously exposure, repetition, which you guys do. But I like this coming at it from Just the Facts, because you would keep a journal and a dialogue, and they were big on a reward system. Try X number of things, you get X number of points, and you get a stuffed animal at the end. And through the years, just to let you know how it's played out, my daughter still eats, a lot of the same foods, but has expanded on that. But as she's gotten older, I think the peer pressure does seep in, and it's like, I'm going to college in a couple of years. I want to be able to eat something. And so we've like started her like rewards chart again. And so this is like, I don't know, 12 years. I mean, it's like been a long road, but we go back to that same testing idea of Just the Facts, little bits of a lot of different cheeses, a lot of different yogurts, a lot of different this or that. And the idea of it works. It just takes time for that person, I think, in their mind to be brave enough and to try to quiet their anxiety and to, move forward and try to, I want to say move past, but, gain more in their arsenal to be more comfortable doing it. So anyway, it just made me think of that experience and wish me luck. Wish her luck. I don't even know, but God bless all of you is all I'm saying, because it isn't easy.
I love that. And I'm sure, like, literally, I am not like trained per se to do this. So I'm sure that there are places that I love that. Like, that seems like a really nice protocol to kind of work with people in a very specific way who had that very specific thing. So yeah, thanks. I'm taking my own notes. Thank you.
And Lynn, your parental input is extremely valuable. So thank you for that.
And to focus on what Lorelai said too, like there would be fights all the time, right? And it's like, it truly, I'm more action oriented. Like, I hate you can do whatever you want type of thing, but it just does create, when you're fighting with it does create way more stress and anxiety for everybody. And so like, they got to figure it out. So let them figure it out and let that be upon them. If something's not there that, they might not like, and they'll, this is of course nobody's losing weight here, got a healthy kid, you know, she's 5'9", like doctors never cared because she was growing properly. But, you know, so not to that degree, but this is just for picky eating, I will say.
Like we
popped
all
one in the chat, Lisa. This was just me being
please.
like, Lorelai, I don't know if you have any thoughts on this. Like, is there any like just strictly like genetic or like biological component to like food preferences? I mean, obviously I know like what parents model or provide in the house will inform like child's preferences or pickiness, but I just didn't know if there was anything fundamentally, you know, that parents like pass down to child, like kind of, and Lynn
Probably.
kind of spoke to it, but yeah.
Yeah, I mean, probably. I think that, you know, from what I've read, there can be a genetic component. I think a lot of it is just sensitivity. So, you know, if they're experiencing smells or tastes at a really heightened level, they can get easily overstimulated and overwhelmed. Even textures, I think, like, yeah, so I for sure think there probably is. I don't know that that's like 100%. I think, again, it could just be like this child has had really terrible experiences with food and that's just imprinted on them. So I think, you know, the nature versus nurture question rages on, I guess. But I think, yes, for sure, some of it can be genetic.
Thank you. That makes total sense. I didn't know if it was a fair question, but appreciate the insight. Yeah. Oh yeah, Lynn, good point. That's very true. Other questions or thoughts? I didn't want to monopolize.
All right, well, I think we can, thank you so much, Bailey and Lynn, for organizing this for us, and Lorelai for your presentation. Thanks for working through the flexibility of